Hi, good day everyone. This is Dr. Iftikhar Sadiq and welcome to my channel on YouTube. First of all, I beg your apologies that I'm going to present this video after a long time. It's almost 2 years that I published my last video. And now I'm trying to explain and present about polycystic ovarian disease, which is a very and the current hot topic in the field of infertility and reproductive endocrinology. I'm going to make 7 lectures that will explain the current concepts of PCOS. The video number 1 will explain the condition itself and its effects on the life of a woman and on the life of a fetus and the newborn. The second video will be about the factors that are responsible for the expression of the PCOS in a patient. The next 3 videos will take into account all factors that are responsible for PCOS one by one. In the sixth video, the current treatment options of PCOS will be discussed, and in the last video, I'm going to present few cases of PCOS with long fertility and treated successfully, ending into successful natural pregnancy. So now let's begin the first lecture. Before moving on to the lecture, please subscribe the channel and press the bell icon so that you can get the notification of the next uploaded video as soon as it is uploaded. Basically, PCO is a disease of recent past, and it is the commonest endocrine disorder after the diabetes mellitus. And in 80% of the patients of PCOS, they don't ovulate, and that is why it leads to subfertility or failure to conceive. PCO, its account is seen in ancient manuscripts, but first authentic account is seen in a paper published by Stein Leventhal in 1935. Ever since the publication of this paper, its prevalence has gradually increased from 9% 4 decades ago to almost 35% during the last decade. Though its prevalence varies in different parts of the world, in Pakistan its prevalence has gone up to almost 52%, as mentioned in an article published in 2015. So it means the in last 3 decades, the incidence of PCO has gone up from almost 9% to 52%. So what has happened in these 30 years of time? Why this disease has become so common, and it is so common in very young girls, leading to difficulties in getting pregnant. And this is why I'm going to present with the series of these lectures, because this is a very common condition nowadays, and it will highlight and enumerate the causes of this sudden increase in the incidence of disease during past 3 decades. PCO is generally diagnosed on the basis of exploring 3 different categories. Number one, sign and symptoms with which patient presents. The presence of these signs and symptoms gives rise to suspicion of polycystic ovarian disease, and to make the diagnosis certain, we suggest some investigations. And those include transvaginal ultrasound of the ovaries and the assessment of the hormones, or we can call them biochemical indicators. So, what are the commonest signs and symptoms in a patient of PCOS? The general, very common signs the symptom in a patient's PCOS is menstrual irregularities, and generally they have prolonged cycles. It means their cycle is more than 35 days and can be up to many, many months. They're generally obese. They can have increased body and facial hair, acne, so fertility or infertility. They can present with repeated early miscarriages and failure to ovulate, especially having regular menstrual cycle but failure to ovulate. In transvaginal ultrasound, we typically find larger ovaries. A normal volume of an ovary is generally less than 7 cubic centimeter, but if the volume of the ovary measured in three dimensions is more than 9 cubic centimeter, it is highly suggestive of polycystic ovarian disease. Not only the size of the ovary is enlarged, but they have a very typical shape or very typical picture on ultrasound. And we and this there are two variants of this picture. One is they have number of uh, small follicles, or we call antral follicles, which are between 5 to 9 in diameter, and they're scattered all over the ovarian mass, as you can see in the first slide. Or very typically, these follicles are arranged peripherally around the ovarian rim. This classical picture of the ovaries. For hormonal analysis, we usually advise five hormones in the early follicular phase. It means the first 4 days of the menstrual cycle. These hormones are FSH, LH. FSH is follicle stimulating hormone, luteinizing hormone. AMH is anti-Mullerian hormone, thyroid stimulating hormone, and prolactin. In past, androgen, sex hormone binding globulin, and fasting insulin were also advised, but now these are of no significance in terms of the diagnosis. Now, the cornerstone of the investigation is AMH, the anti-Mullerian hormone. It can be within normal range, but in most of the cases it is, and the cutoff value suggested by us, published in a paper cited here in this paper, is 3.9 nanogram per ml. Higher the AMH, larger the ovaries, and more resistant PCO is seen. PCO, as it generally in general public, it is considered as it is causing the infertility or the menstrual irregularities. But this is the one spectrum of the polycystic ovarian disease. Polycystic ovarian disease is a disease with a very wide spectrum. It is linked to many other complications from virtually every part of the body. It can lead to infertility, obesity, hyperlipidemia, dyslipidemia, type 2 diabetes mellitus, hypertension, metabolic syndrome, and masculine appearance. There is also 60% increased risk of early spontaneous miscarriages. Even if a patient with PCO have successful pregnancy without having any prior treatment, the PCO can lead to complications in pregnancy and in the fetus in this patient. And these complications can be low birth weight babies, small gestational age babies. There are more chances of stillbirth and perinatal mortality, more congenital abnormalities, low APGAR score at the time of birth, and the babies born with the maternal PCOS have increased risk of autism spectrum disorder by 60%. In a female fetus of a patient with complicated PCOS, there are high chances that the lady who is born out that female fetus can have high in poly, incidence of polycystic ovaries after the birth. Their AMH can be very high. There can be early childhood ovarian dysfunction, and when they reach puberty, they can also have obvious and clear polycystic ovaries. And if the fetus is male, it can also be affected by the maternal polycystic ovarian disease. We can find the higher body mass index in early childhood in a male fetus, in a male baby. There is increasing evidence of insulin resistance in older ages, higher waist to hip ratio in childhood. Babies can be overweight and they can have smaller testicular volume. Women with with untreated PCOS, they are at more risk of heart diseases. There is a 2.7, almost 3 times increased risk of developing endometrial cancer in the later ages. They can have, they can, out of 5, 3 ladies with PCO can have depressive or anxiety related disorders. They can have sexual dissatisfaction, poor self esteem, and psychological distress. The prevalence of hypertension and diabetes mellitus type 2 is increased in the patients with PCO with excess weight. It is estimated that the 40% of the patients with excessive weight can have overt or clear cut diabetes mellitus by the age of 40. So it means the PCO not only causing infertility or menstrual irregularities, it is a metabolic disorder. It is affecting almost every part of the body, and these effects, which includes hypertension, diabetes mellitus, non-alcoholic fatty liver disease, miscarriages, and many more. And they can, these PCO abnormalities can also affect the newborn, whether it is a male or a female. So here I conclude my first lecture. In my next lecture, I will describe the factors and the causes that are responsible for the polycystic ovarian disease and this sudden rise in the incidence of polycystic ovarian disease. Thank you very much.